Hello, everyone. It's great to see you. Welcome back to our CalMap Echo for primary care providers. Thank you for sharing your lunch hour with us. As you're coming in, as usual, go ahead and just drop into the chat your name, what county you practice in. And so we just have a sense of who's here as we're coming in from across the state to learn together. And as you're dropping in your name and your county and into the chat, let's just take a moment to ground ourselves just for a minute. Let's just go ahead and move into the next slide here. Yeah. So one of my favorite sort of grounding techniques and breathing exercises is square breathing. And for those of you who aren't familiar with it, you breathe in for a count of 4, you hold for 4, and then you breathe out for 4, and you hold for 4. Now let's just go ahead and take a moment to do that now. If you want, just kind of close your eyes. And this is just our moment to kind of drop whatever our morning brought to us and whatever we're carrying at the moment, so we can be present. Okay. Let's start. Let's breathe in for 4. Let's do that again. Breathe in. Breathe out. Let's try that again. Breathe out. Hold. Breathe out. This time, let's breathe in. Hold. I like to do that with my patients, and I let them know the Navy SEALs do this as part of their training, just to help themselves to be fully focused and present no matter what stressful circumstance they're in. I figure if it works for the Navy SEALs, it should work for me. But welcome again to our Project Echo. Please do keep on dropping your name, your organization, your county into the chat so we know who's here. And with that, let's go into a few announcements. So the next slide, please. Okay. These are a few of our disclosures from today. Our speaker does have a research grant from Jazz Pharmaceuticals, but all relevant financial relationships have been mitigated, and there are no other financial disclosures to share for today. Just a little word about our federal and state grant funding, which allows us to provide this program to you. Next slide, please. Just a couple of reminders, housekeeping. For all of these before we go into our introductions and learning objectives for today. One is please do keep your cameras on. I know that a lot of us are eating, etc. Please eat on camera, but this is a chance for us to just see each other, to interact with each other, especially during the case discussion. It's great for us to see each other and try and build up a little community here. We will be recording just the lecture portion, but not the case discussion. So, so just be aware of that. We have this, this activity is eligible for the core badge. And so for those of you who have been attending so far, if you can continue attending all the way through the 6 sessions, you'll be getting a core badge that you can share on your CV, on your LinkedIn, etc. Just a little incentive and way of crediting you for the time and effort that you're investing into your pediatric mental health education. And finally, if you have a case that you want to share with us, case-based discussion is really how we learn here at Echo. And so please let me know at the end of this session today if you got to share that, if you got a case to share in one of our upcoming topics. And with that, I want to introduce our speaker for today. We're lucky to be hearing from Dr. James McCracken, who is a professor in residence here at UCSF in the Department of Psychiatry and Behavioral Sciences. He's also a consulting psychiatrist here at CalMet. Dr. McCracken specializes in the safe and effective use of medications for the treatment of a variety of childhood psychiatric and neurodevelopmental disorders, including ADHD, autism, OCD, and tic disorders. He received his medical degree from Baylor College of Medicine, completed general psychiatry residency training at Duke Medical Center, followed by a combined child and adolescent psychiatry clinical and research fellowship at UCLA. Dr. McCracken previously served as Child Psychiatry Division Director for 30 years at UCLA before joining UCSF. With that, I'd like to turn the floor and the virtual mic over to Dr. McCracken.
Good afternoon, everybody. Thanks for joining. It's great to see folks from up and down the state. So we wanted to take you through a primer on ADHD and kind of make sure everyone is up to speed on the evidence base for our treatments, which are excellent, and importantly, how to optimize them. We want to talk about not only the first line treatments, but also the range and increasing number of non-stimulant treatments that we have for ADHD, discuss side effects, and be able to recognize when perhaps referral to specialty mental health may be advised. Next slide, please. We're relying on the American Academy of Pediatrics practice guidelines as sort of the foundation here, and we do recommend that you all familiarize yourself with them. They're straightforward. They apply to preschoolers, to teens. We do abide by the DSM-5 criteria for making the diagnosis, with an emphasis on a full evaluation, including collateral information, assessing for common comorbidities, ruling out those conditions that often masquerade as ADHD. This is treated, of course, as a chronic health condition. And we can talk a little bit about long-term outcome as well. The guidelines actually are very consistent with child psychiatry guidelines, with other international guidelines, Canadian, Australian, UK, that for preschoolers with ADHD, behavior therapy, rigorous behavior therapy is considered first-line treatment, with methylphenidate as second line. The rationale for that is that the efficacy of stimulants in preschoolers is reduced, and at the same time, the side effect risk is increased in preschoolers. We can talk more about that if you have particular questions. Then for school age and teens, young adults, first-line treatment, methylphenidate or amphetamine-containing stimulants, with a strong recommendation to involve behavioral, psychological, and educational interventions. Certainly, one of the things that comes through loud and clear from comparisons of community practice to more research or academic settings is the need to optimally titrate doses in order to maximize benefit and really reach those high bar goals for treatment at the same time of tolerating side effects and arriving at optimal doses. And one of the new things in ADHD is that some changes in the definition of what's adequate treatment or what the goal for treatment is, specifically a reduction of either 50% of ADHD symptoms from treatment initiation, or the equivalent of what's referred to as normalization. And so for using a Vanderbilt or a SNAP scale, that would translate to an average score per item of 1 or less. We can discuss that further as well. And then given the comorbidity of ADHD with many other disorders, screening for those common conditions is considered standard practice. Next slide, please. So I mentioned that across the board, these practice guidelines are in very close agreement. I think the things maybe to point out that at times have been under discussion are things like what about laboratory testing, neuropsychological testing? These guidelines agree those are not considered requirement for the diagnosis or initiation of treatment. Obviously, there are individual cases where a child who's slow to learn to read, for example, or where there are concerns about cognitive performance, where neuropsychological testing is very important, especially when it comes to eligibility for accommodations and the like. Certainly include the inclusion, as I mentioned, of behavioral therapy and other non-medical therapies show up in all of these clinical practice guidelines as necessary for optimal response. And then one other sometimes controversial requirement suggested in some institutions has to do with should an EKG always be obtained before initiating a stimulant? And again, the guidelines all line up on this, that it should not be considered a requirement, but we do strongly recommend including screening for those things that may relate to increased risk for adverse cardiovascular responses to stimulants, such as history of heart murmur or congenital heart anomaly, family history of sudden death before the age of 45, family history of Wolff, Parkinson, White. But overall, those represent a minority of kids that we're encountering. Next slide, please. I'm sure all of you are familiar with the diagnosis, as mentioned, according to DSM-5. And the criterion haven't changed much, going back to DSM-4. The more recent modifications, just to be sure you're aware of, usually for kids less than 17, they are required to manifest at least 6 or more symptoms of one of both of either domains, either inattentive or hyperactive impulsive symptoms, in order to meet criteria for at least one subtype of ADHD. And that at least 1 or 2 of those symptoms need to manifest before age 12 as the standard. The more recent modification of the criteria includes, for individuals 17 and older, that only 5 or more symptoms are required per domain in order to be considered to meet criteria. And that these symptoms need to be understood to be causing functional impairment or interference in more than one setting. Next slide, please. We love free scales here at UCSF, and I know you do too. And both of these scales are very well validated, easy to use, help you gather this information in a way that's really efficient. You can do this prior to stepping into the exam room, and they provide a lot of information. We know that without these scales, we risk not appreciating the full presence or the full diagnostic picture. So both the Vanderbilt scales and the SNAP scales are very useful. I love the SNAP scale. The 90 item scale is probably what I would consider using if this is my first encounter, if I'm considering doing a diagnostic assessment. But I love the 26 item scale for monitoring because it includes the 18 cardinal symptoms of ADHD mapping right onto DSM-5, but it also includes 8 of the DSM-5 oppositional defiant disorder symptoms. And those, with ODD being comorbid in 30 to 40% of kids with ADHD, this is highly relevant. These scales are great for monitoring and highly recommended to be utilized as such, both with a change of dose as well as ongoing treatment. And my recommendation is, given the pace and rhythm of a child's experience in school, every 3 months during the school year is my practice. I want to be sure that they're getting the most out of this treatment, and that I'm not overlooking what may be some deterioration or need for dose adjustment, et cetera. Next slide, please. So ADHD really serves as kind of a universal risk factor for psychopathology. It's quite remarkable in that way because no matter what your favorite form of psychopathology might be, mood, anxiety, other disruptive behaviors, oppositional defiant disorder, conduct disorder, et cetera, they're increased in kids with ADHD. You can expect that fully 2/3 of those kids and adolescents that you see who meet the DSM-5 criteria will have at least one other co-occurring disorder, as shown here. For anxiety and depression, my rule of thumb is about 1 in 4, 1 in 5 will likely meet criteria. But you'll see, 10 to 15% of samples of kids with ADHD to have tic disorders. Talked about ODD already, autism. If you're working in a clinic for kids with neurodevelopmental disorders, I'm sure you're well familiar that you're going to see rates of DSM-5 criteria ADHD, approaching 50%. Even in community samples, 30% meet criteria. So what the main point, screen broadly, look far and wide for these common co-occurring conditions because they're obviously going to need to be built into a comprehensive treatment plan. Next slide, please. Psychoeducation, hugely important. There's so much misinformation, obviously, about ADHD, and parents and older kids will likely benefit greatly from understanding, ADHD is not caused by poor parenting. And the causative factors or risks may vary from individual to individual, but the role of genetics is quite large in ADHD. Heritability risk estimate above 70%, but environmental factors play a role too and can be quite prominent. Likewise, for recommendations building into your treatment plan, the importance of behavior therapy, helping parents appreciate what's really going to work best in trying to manage their troublesome child's behavior, and really shifting from what all too common is a very intrusive, controlling, punitive style of parenting, and trying to flip that to an emphasis on positive behavior, rewarding pro-social behavior, uh, really changing that family environment, as well as, helping parents appreciate what can be ignored, and, what to kind of let go in the service of, improving their relationships and reducing that tension at home. What to start with first? Well, besides the recommendation regarding preschoolers, this is an individual choice, I think, depending on your clinical situation. There's no problem with starting both together. Some parents will prefer accessing behavioral therapy first, and then you following up and looking at what's left over. I think the case can be made equally to start the medication, looking for what improvements, what changes take place with treatment, and then honing in with behavioral treatment uh, at that point. Pharmacotherapy, as we said before, stimulants first line. Next slide, please. There's a lot of great resources out there for psychoeducation, and I highly recommend both these books, but also the online resources, both the attitudemag.com, the CHAD website is quite comprehensive. NIMH.gov also has an ADHD site as well. Next slide, please. We talked a little bit about the components of behavior therapy already. Basically, they're helping parents develop a much more systematic approach to targeted behaviors, and including, improving instructions, and using rewards and reinforcers. And as I said, really focusing on positive behaviors. Next slide, please. School accommodations, many kids with ADHD will qualify for school accommodations, either the 504 plans, and especially with a supportive teacher, these can be very powerful, and some requiring IEPs for under the designation of other health impairment. It's important that parents know that they need to submit a request for an evaluation in writing in order to prompt the school to follow the legal mandate of follow-up in 60 days or less. Next slide, please. The FDA medications fall into two main categories: stimulants, non-stimulants, two classes of stimulants, methylphenidates, amphetamines, and then now three different non-stimulants, the alpha agonists, and the newest approved medication for ADHD, viloxazine or Quellbray, along with atomoxetine. Next slide, please. Stimulants are remarkably powerful, and they affect a broad array of symptoms. They're amongst the most powerful treatment that we have in behavioral health. You can expect a response rate of about 70%, although non-response to a methylphenidate only or an amphetamine is not rare, probably 1 out of 3 or less. Common side effects often are transient, but include appetite, weight loss, insomnia, stomachache, and headache. Next slide, please. Here's some suggestions regarding managing these common side effects. loading up with protein-rich breakfast, making sure that the child has something in their stomach before the medication, um, getting around insomnia, actually shifting the timing of the medication, um, perhaps trying to lower the dose, maybe shifting to a less longer acting formulation, and then at times using a sleep aid. Um, the wear-off phenomenon can be quite prominent in some kids, and in that case, either shifting to a longer acting or trying a booster dose can be helpful. Next slide, please. The choice of the stimulant depends a lot on the individual child and their behavior and their demands. But the the positive thing is that we have both short-acting, immediate release preparations, 4 to 5 hours in duration, with what I consider to be intermediate length treatments like Ritalin LA or Focalin XR, which have a duration of action of 8 hours, maybe 10 hours, and then the very long-acting uh, preparations like Concerta, Vyvanse, and the like. So it's worthwhile taking time to try to match what the demands and needs are. But usually for school age or older, you're going to be looking at some form of extended release, either that middle range or longer acting. Next slide. How to keep track of all of the preparations. I recommend this ADHD medication guide, which you can pull down online. It's updated regularly. I think the important thing to simply mention here is that we have liquid formulations, chewable tablets, oral disintegrating tablets, sprinkable tablets or capsules as well. So we have quite a bit to be able to individually match to the needs of our patient. Next slides. And next one. Monitoring, I think this is important, both in terms of just keeping track of cardiovascular changes, weight and height, and then symptom response. But I strongly encourage employing a structured tool to capture side effects because when it comes to adherence, side effects are maybe the biggest contributor to poor compliance and dropout of treatment. Next slide, please. Non-stimulants are available. The caveat is that they're not as effective as the stimulants, but worthwhile for some of those harder to treat kids who don't respond to either a methylphenidate or an amphetamine-containing preparation. Different side effect profile, of course, in the stimulants, but we have extended release preparations of both guanfacine and clonidine that are quite helpful. I prescribe these both BID in order to smooth out the response and lower the rate of side effects. Next slide, please. Usually with these alpha agonists, kids and teens are remarkably adaptive and tend to see a resolution of side effects quickly, but I usually don't change dose for about every 2 weeks as I'm titrating up. Next slide, please. Atomoxetine, actually the first non-stimulant approved. Decent benefit rates. Some unusual side effects not seen with the stimulants as shown here. Some question about whether the dose guidelines in the drug information insert are appropriate, given that evidence suggests that higher doses may be needed in kids to optimize the benefits of these above the recommended level of 1.4 milligrams per kilogram per day. I also dose this BID rather than once daily. Next slide. And then the newest non-stimulant is viloxazine or Quelbray. It's been used as an antidepressant in Europe for over 20 years. Also kind of a medium benefit rate or effect size, as you can see. Tends to be a little more sedating, can cause GI side effects and insomnia. Might be a good fit for those kids with comorbid mood and as well as ADHD. Next slide. So putting it all together, this is kind of drawing from the clinical guidelines. Usually a trial of stimulants from both classes. If benefit is not seen first go around, and then considering the alpha agonists or the non-stimulants as usually third line. They can be combined safely with stimulants, and this is a possible way in which to really optimize treatment for those tough to treat kids. And then other medicines that have some evidence of benefit but are not approved or off-label would include bupropion. Next slide. Well, thank you for this fast-paced review of ADHD.
Thank you so much for that great talk.